So one of the new agents that has become available to us in the last decade or so to treat CLL is venetoclax. And in many ways it represents a paradigm shift in the way we think about CLL, because it for the first time allows us to get really deep responses in patients with relapsed and refractory disease. So it's been an enormously exciting addition to our therapeutic armamentarium in this disease. However, one of the challenges with venetoclax monotherapy, at least in the relapsed and refractory population, is that it looks as though most people over time eventually develop resistance to the drug. So our work has focused for a number of years now on trying to understand why resistance occurs, and hopefully going forward to target recognised resistant mechanisms to try and prevent patients developing resistant disease, and to let them have better quality of life with better disease control for longer. One of the obvious ways to try and prevent patients developing resistant disease is to use combination therapy. And one of the really promising combinations, at least in the relapsed refractory setting, is venetoclax and rituximab. Based on John Seymour's Murano data, we know that for the first time, immunotherapy with venetoclax is superior to chemoimmunotherapy, allowing us to treat patients to deep remissions, long progression-free survival, improved overall survival, and giving us the opportunity to stop drug so that patients can have a period of time off all treatment with well-controlled disease. One of the challenges in the venetoclax in the CLL space is recognising robust biomarkers. Most patients will respond, but the real challenge is trying to work out which patients are going to have a prolonged progression-free survival and which patients are eventually going to go on and develop resistant disease. One of the key paradigms that we're starting to see is that MRD really stratifies patients by risk of progression. So patients who achieve an MRD negative response have a prolonged progression-free and a prolonged overall survival compared to those patients who fail to achieve a deep level, so MRD negative disease. We know that MRD can be measured in a couple of different ways, via PCR or via multicolour flow cytometry. These two techniques appear to be equivalent, as does the compartment that you measure. So MRD measured in the bone marrow appears to be similar in terms of its prognostic significance to MRD measured in the peripheral blood, and there is a high correlation between the two results. So we're really learning that testing MRD by whichever method is most easily accessible to your laboratory has real prognostic implications for patients, and the good news for patients is that this can be done on the peripheral blood as accurately as it can be done on the bone marrow.